Supratik has left. Supratik spoke beautifully about the basal insulin. But then still we thought that, you are using basal insulin, but really we still need a better insulin. For the reasons that best known to all of us, that basal insulins purely will have some time action caveats, some injection time caveats because of its typical time action profile. And also there is some inter-day variability and there is also some intra-day variability. So we wanted to have something still better, more than 24 hours, because we all know that injectable glargine will have a half-life of around 14 to 16 hours. But at the end of 24 hours, the pharmacological levels, they start going down. And that is the reason why sometimes, especially in places like Mumbai, where Dr. Manoj and Narayan and all those people, they have seen that the traffic in Mumbai, suppose somebody is caught in with, you are quite likely to miss the particular time caveat that the glargine carries. And that is the place where people started looking at some better basal insulins. So I'm going to talk to you about glargine U300, a more concentrated form of glargine U100, where the surface area was reduced. Thereby, surprisingly, the quantity was definitely going down as far as the injection volume of the injection is concerned. But because the surface area went down, the time action profile became better and the insulin had a more protracted effect of nearly around 24 to 28 hours. Now that is the beauty of this insulin. So let's talk about importance of this titration. Landmark, Supratik talked about, he spoke about that maybe probably East showed a better response to glargine, possible. And of course, we know that we still are very, very reluctant people to use insulin in our day-to-day clinical practice. And there are challenges, we all are aware about it, and especially where we fail miserably, maybe one in the initiation of the insulin, but we fail genuinely badly in intensification of the insulin therapy. And the worst is what? The last para that you can see. You tend to intensify when HbA1c is nearly 9.2. That is the place where India stands. That is the reason why 8 out of 10 people, despite on being on insulin, they fail to achieve the glycemic targets. Poor initiation and even difficult and very poorly advocated intensification of the therapy. And this was a beautiful paper which came out as an expert opinion on the Delphi consensus. And this was Dr. Sunil Jain and Dr. Unni and Manoj and in team. They said that probably we initiate much lower. So everybody recommended that can you go a little bit up? So rather than from 0.1 units, can we go to 0.15 or around 0.2 units per kg per day? And then they did a Delphi survey. And what they found out that overall we do far better when we initiate people with around 18 units per day and then intensify. But the beauty of this insulin is that this can be intensified up to 0.5 units per kg per day. Now that is the beauty of this insulin. And apart from the ease of up titration, what is most important is it's still very safe. We are all bothered about hypoglycemia, and we should be bothered about hypoglycemia. Surely we should be bothered about. So whenever you talk about insulin injection, you are talking about hypoglycemia. So once we are bothered about hypoglycemia, it is notable that glargine U300 has much lower overall hypoglycemias, but significantly lower nocturnal hypoglycemias. So the patients, it is absolutely ease as far as the injection is concerned, lower volume, so lower pain. You did get a timing flexibility of around 3 to 5 hours. So plus or minus 3 hours here, plus or minus 3 hours here. Even though you miss that particular timing, you don't have to be really bothered about it. And for physicians and for the endocrinologist and diabetologist, it is easier administration, lesser hypoglycemia. So lesser monitoring and lesser concern, and which will ultimately lead to lower weight gain. So you need to balance whenever you are adjusting the insulin therapy. We know that we need to balance between hypoglycemia and optimal diabetes control. So glargine U300 for me is extremely safe for titration with minimal weight gain. That's what I said. Flexible dosing timing, very stable, lower intraday variability, less glycemic variability, better time action profile, so better time in range, and less hypoglycemia overall, but significantly lower nocturnal hypoglycemia, which is sometimes responsible for what we know as a dead in bed syndrome. And we do have got a strong evidence. There are so many, randomized control trials and the real world trials, not only in comparison with glargine U100, but insulin IDEG as well. And we are going to talk to you about 2 or 3 of this in brief. So first was an edition program. There are 5 different editions or 7 different editions which looked at type 1 diabetics, comparison with U100 on OADs in Asian patients, in Japanese patients. And the people were randomized in one arm with glargine U300 and on the other arm is glargine U100 with OADs. And the study of 6 months was done, and they looked at what the glycemic efficacy of the drug, and also the most important primary endpoint was to look at the lowering of the overall hypoglycemia and the nocturnal hypoglycemia. And you can clearly see on the slide deck that all the points, they lie to the left of the line of unity. That means that they are favoring glargine U300 as far as the overall hypoglycemia is concerned, as well as the nocturnal hypoglycemia is also concerned. Edition 1, 2, 3 showed that glargine U300 is not inferior to glargine U100. See, remember that glargine U100 is a standard of comparison. Any new insulin which has to come into the market, no matter it could be ultra rapid, or even a newer, longer acting analog, it has to prove its non-inferiority to basal insulin like glargine. So glargine is a standard of comparison or standard of care. Glargine U300 proved its non-inferiority in all the edition trial with much lower hypoglycemia, and nocturnal hypoglycemia goes down by nearly 50%. So every 1 in 2 patients get benefited. Bright study looked at the patients, those who were randomized between IDEG and glargine U300. And they looked at the same outcomes. They looked at the glucose control, so glycemic ability of the glycemic lowering ability, so glycemic efficacy of the glargine U300, as well as the lowering of the nocturnal and the oral hypoglycemia. You would clearly see that they are both comparable, IDEG as well as glargine U300. But what is significant is that glargine U300, surprisingly, which we still do not know the exact reason why this is so, but has shown a much lower hypoglycemia as an overall issue or as far as the nocturnal hypoglycemia is concerned. In type 1 diabetic patients or the type 1 arm of Bright study, it was surprising again to see that glargine U300 are a very, I would say peakless flat profile in comparison to IDEG. That was surprising to me when I prepared this slide deck, but this is true. That was very interesting, and hence when people were asked the questionnaire about their comfort about using this insulin, everybody said that we are very comfortable. So what we call it as the diabetes treatment satisfaction score was very good in the patient those who were receiving glargine U300. So how do you start? Generally the initiating dose is little higher in comparison to glargine U100. Now here it is around 0.15 to 0.2 units per kg per day. What time? 2 or 3 hours you get a flexibility plus or minus. Can it be given with OADs? Yes, absolutely any OADs. Can it be compared with combined with GLP receptor agonists? Yes, it can be compared. You can up titrate up to 0.5 units, and in obese patients you can even go up to 1 unit per kg per day. Fantastic duration of action, better glycemic control, and throughout lower risk of hypoglycemia. A wonderful device to administer. We all know the ease of administration is also a determining factor for the satisfaction score. So this is an insulin which comes and which can be delivered by one of the best possible insulin injection pens. So this is a wonderful device to use. I don't know how many of you had an experience with this, but if not, I would surely recommend you guys to feel that. So to summarize, friends, Glargine U100 changed the way we practice diabetes. They gave us a far better insulin in comparison to what previously we all have used, like Lente and MPZ and the previous generation insulins. But then the newer second generation basal insulin analogs like Glargine U300 has probably eased out the insulin initiation and the up titration in a far better way. So the acceptance in the healthcare providers as well as the patients is genuinely wonderful. Thank you very much for your kind